My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly. My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening and a very warm welcome to this penultimate episode of Lectures of Distinction, a very popular educational initiative by BOFAS, which has been hugely successful. It is my pleasure to invite consultant orthotist Nick Gallogly, who is a colleague and friend. He is head of service and orthotic clinical lead at Royal Berkshire Hospital, Reading. He specializes in biomechanics, gait analysis, and neuromuscular lower limb conditions. Nick qualified as a mechanical engineer, followed by an honors in prosthetics and orthotics, and then went on to have masters in clinical biomechanics. He supports a large number of professional teams, including GB rowing and para rowing for the last 10 years. He works in multiple hospitals. He has a huge interest in education and research, and has recently written a chapter, a very good chapter, I would say, in Essentials of Foot and Ankle Surgery. I am looking forward to learn a lot from this talk. So I would like to invite Nick. Over to you, Nick.
Thank you very much, Manish, for that very lovely introduction, and good evening to you all, and thank you very much to the Education Committee for asking me to present to you this evening. We've had some fantastic talks throughout this Lectures of Distinction, and in every component of that talk, there has always been a small section on the role of orthoses in conservatively managing our patients. And hopefully I'm going to give you an insight into the principles of how we come up and design our orthoses. I'm going to try and talk about the different reasons for referral, the importance of functional anatomy when we think about the design of an orthosis, talk a little bit about the different materials that are available to us. And for the purposes of this talk, we're going to be exclusively discussing functional foot orthoses and ankle foot orthoses. And then remember, personally, as an orthotist, we treat the whole body, from protective helmets for craniectomies right down to functional foot orthoses. We're going to also discuss footwear and the role of footwear, and we'll have some examples throughout to try and bring this talk to life for you, and hopefully some discussions within it as well. I would have liked this talk to have been about 6 hours long, because that's how long I feel I need to be able to convey everything that I would love to convey, but that is not the right, and it's certainly not what you guys need to know. But if you're attending BOFAS next week and you find me, you're very welcome to come and ask me some more questions if you are so inclined. So let's get the basics out of the way. What is an orthosis? And an orthosis is a medical device that we apply to an external part of the body, either a joint or a limb segment, with the aim of trying to reduce load upon a pathological soft tissue or joint, try to resist a deformity, and ultimately trying to reduce pain and improve someone's mobility. Whilst there are some orthoses that apply a correction and corrects a limb segment, the majority of orthoses influence a body segment, meaning that when an orthosis is removed, the foot, in this case, remains in the position it was before we set out on our journey of conservative management. So when do you refer to an orthotist? Or, of course, if it's foot and ankle, it will also be some of the excellent podiatry colleagues that I work with as well. You refer when you have a patient when you feel that the symptoms don't warrant surgery, when the patient is not fit for surgery, or indeed they're not the right person for surgery, but you think that there is a surgical solution for that patient. Maybe you refer someone for a foot orthosis or an ankle foot orthosis whilst they're waiting for surgery to occur. And, you know, there are times when you refer someone for an assessment because you genuinely think that conservative management is the appropriate methodology in managing your patient. I personally think that there are more reasons as to why you might refer for an assessment, but maybe that is for later on in the talk. Now, this was mentioned in the gait analysis talk, and that is the importance of functional anatomy. And I bring it up again because of how important it links to the design and the prescription of functional foot orthoses and ankle foot orthoses. And to recap, concentric contraction is the shortening of a muscle when it provides a movement across a joint. And eccentric contraction is the lengthening as it provides control about a joint. And sure, that is incredibly important to know. And if you're geeky enough, you want to understand every muscle across the foot and ankle and where and when it concentrically and eccentrically contracts. And that's very important. But what's also important is understanding when in the gait cycle that muscle eccentrically and concentrically contracts, and also for how long. And here's a graph on the right-hand side that demonstrates some of the peak activations of some of the more common foot and ankle muscles. So let's take that directly into a patient that we're going to see tomorrow morning, and a very common presentation in tibialis posterior tendon dysfunction. Now, we know that there are lots of classifications, and there are 3, but for the context of this, we're going to be dealing with the flexible tibialis posterior, so our stages 1 and 2, where we're going to be able to apply a force to influence that limb segment. Remember that tibialis posterior is a biphasic muscle. It eccentrically contracts at initial contact, controlling the rate of pronation at initial contact, and it concentrically contracts as it supinates the foot, preparing the foot to become a locked midfoot to allow for powerful push-off from the metatarsal heads towards the end of terminal stance. Okay, so with that in mind, what are the aims of a functional foot orthosis? Well, the aim of a functional foot orthosis in the presence of a stage 1 or a stage 2 tendon dysfunction is to decelerate the rate of pronation at initial contact and reducing that eccentric lengthening, to reduce the anterolateral compression and reduce some of the pain within the sinus tarsi, to reduce the amount and the effort that's required of concentric contraction, and ultimately to protect the ligamentous structures from becoming attenuated because of that cascade effect. And then also to ultimately reduce pain, not to support the arch. When we're looking at pathology and we're assessing our patients, it's really important to understand the different planes of motion. And my view is that we should also try to identify the primary plane that is driving that position, that foot deformity, whatever it might be. And in the lion's share of patients, those deformities are either driven by something in the sagittal plane, i.e. a tight calf muscle, leading to forefoot metatarsalgia pain, or in the frontal plane, where we may have a plantar flexed first ray in the presence of a pes cavus foot. If we can influence the primary plane, we might be able to then reduce the load upon the tissue and maybe reduce the pain. Also remember that with a deficit or pathology in one structure comes a cascade of deconditioning in other structures. So whilst we may have the primary issue of tibialis posterior tendon dysfunction, we then have weaknesses occurring and a deconditioning across the other structures. And that's why it's important to refer our patients on for physiotherapy in conjunction with maybe the intervention and the prescription of a functional foot orthosis. So here's a really simple, valuable test that you can apply to your patients first thing in the morning. And it's really, really simple. It's called a supination resistance test. So you get your patient with their shoes and socks off in front of you, and you ask them not to help, and you apply one finger underneath the arch to see if you can lift the arch. If you're unable to do that, move on to using one hand. And if you're unable to move it at that stage, try to use two hands. What it does is it identifies and tells you how much effort is needed to try and change the shape of that foot and thereby offload tissue. But it also tells you how much damaging forces are acting upon that soft tissue. So for example, if you have someone that has pain within tibialis posterior and it's very easy for you to lift the arch, maybe a more minimalistic off-the-shelf device will be able to apply the appropriate forces to influence that foot. But if the forces are very high and you cannot move that foot at all, we are going to need a little bit more thought around the orthosis design, and more than likely, we will need a custom orthosis. So here's another patient. We have a lady that's presenting with first and second TMTJ arthritis. And as you can see from the picture on the left-hand side, she has a reduction in range through her ankle. But when she stands, she has forefoot abduction and extension and compression through the mid-tarsal and the tarsal-metatarsal joints, leading to symptoms. So in the context of this patient, if we're trying to understand why there is load upon the tissue, which is more beneficial for this patient? A raise underneath their heel to prevent the compression acting upon the midfoot, or a referral asking for a medial wedge or an arch support. I would argue that the use of a heel raise is going to be more powerful in reducing the stress and the strain acting upon the soft tissue and reducing the compressive forces across the midfoot. So with that in mind, what advice are you going to give this patient? Are you going to advise them to continue to walk around in very flat shoes? Or are you going to say to them to work and look towards wearing a shoe with a slight heel pitch to offload their midfoot, whilst you maybe refer for a functional foot orthosis, which would have a stiffness across the midfoot, and maybe consider whether or not a guided injection is appropriate for that patient. There are lots of different types of materials that we utilize in the orthotic industry, and it is not just plastics. But there are lots of questions that we need to be able to understand before we decide that material. It's dependent on the forces we need to apply. and also the forces that we need to increase or decrease. If we've got medial tibial stress syndrome, we like to give greater shock absorption. So therefore we want something that will give us more compression. If we've got a diabetic foot, we want to reduce the amount of shear force. So we'll use a different kind of material for that. Sometimes we will use different materials because we want to provide an increased amount of control to the hindfoot in the example of a subtalar joint arthritis. Sometimes we will have change the material choice we use because the environment that we use. In the case of my GB rowing colleagues, we will need to use a material that's more robust for getting wet all the time. And ultimately, if we're prescribing something, we want something that's going to last a decent level of time and they're not coming back into clinic in 3 months because that material has compressed beyond its value. And these are lots of different types of materials that we utilize. You can see in the picture on the center, we have an array of different types of orthoses. On the left, we have a ground reaction AFO, and then we have a solid AFO, a hinged AFO, and then the black is a posterior leaf spring AFO, and the next one is a dynamic ankle foot orthosis. But we also still utilize the use of below knee irons. It is not seen as an old world prescription. It is a very valid and utilized orthosis and material choice when we are dealing with someone that has reduced sensation or volume fluctuation, because a lot of the orthoses that we design are based upon volume matching. And if that patient has got fluctuating edema that is changing throughout the day, we are unable to prescribe something made from either a composite, for like a carbon fiber, or a polypropylene. But because it's 2022, we're also now using our 3D printed options and different polymers to allow us to be able to come up with the right combination of stiffness and flexibility and compressive characteristics throughout the full design of the device, rather than just having a blanket device made of one material with one single property. There are lots of different types of characteristics that exist when we are looking at the design and the prescription of functional orthoses. And whilst I don't want to become a formulaic in what we should be prescribing, it's still important for you to understand the principles behind what these modifications do for our patients. So the first one on the far left is a metatarsal dome. And whilst we generally can agree that the aim of this is to offload the metatarsal heads and increase the interdigital space in the management of a Morton's neuroma or a bursitis, we know when we start to become a little bit more clever that what we're also doing is decelerating the rate of plantarflexion of the metatarsal. We are increasing the stability across the transverse arch in the presence of someone with hypermobility. The next one over from the left is a metatarsal bar. This is something that gives more globalized offloading to the forefoot. And that is very helpful in a patient with rheumatoid arthritis with a reduced fat pad, with fat pad atrophy and increased pain across the metatarsal heads. The next one in from the left is what we call a reverse Morton's extension. This is aimed at applying pressure between the fifth and the second metatarsal head to offload the first metatarsal head in the management of either a plantar flex first ray in the presence of a cavus that is driven by a plantar flex first ray, or indeed if we have a sesamoiditis or a functional hallux limitus. The furthest one, and on the right-hand side, that is a Morton's extension. And in this particular case, that device has a Morton's extension in a carbon fiber. We use that type of device when we are trying to restrict movement across the first MTPHA for hallux rigidus or for other types of presentations where the range of movement across the joint is painful. So here's a case study. We have a professional rugby player that is presenting with a painful grade 2 turf toe. They're generally comfortable day to day, and they have a good level of passive range across the joint, but on sustained loading, they have got a high level of pain. And you can see from this image which foot is the problematic foot. So how are we going to manage this foot, and what type of orthosis is most suited for managing this type of symptom? Well, it was the last device that we just looked at. It was the functional foot orthosis with a Morton's extension. giving stiffness across that joint to allow the patient to apply that sustained force without that joint reaching its maximum extension, which can lead to discomfort across the joint or indeed the ligament attenuation of that joint. When it comes to ankle foot orthosis, there are many different types of devices, all with their positives and negatives, all made from different materials. But the main principle of an ankle foot orthosis is to influence stance phase. Every AFO, regardless of how clever, how minimalistic, how expensive, how inexpensive, will lift the foot up in some degree during swing phase, some better than others. So the AFO is designed to work on stance phase. And there are lots of different types of prefabricated ankle foot orthoses, when prescribed correctly, offer excellent outcomes over something that is custom made. There is no such thing as a simple drop foot. There are many variations of that, and it's absolutely fine with the patient that presents with drop foot to refer them for an AFO. You're absolutely correct in what you've done, but it's our job to understand the complexity of that drop foot to find the right orthosis for them. So let's look at a patient that presents with a non-operable Achilles rupture. Remember that we all try to understand what the eccentric and concentric work and is of the gastroc and soleus complex, and the eccentric control is controlling the rate of the progression of the knee over the ankle, and concentrically, we all know, is that push off at terminal stance. So when we've got a patient that's elderly with an Achilles rupture, they may be presenting with more instability and a lack of balance rather than a feeling of lack of push off. So therefore, the aims of an orthosis in that particular case is to increase the stability of that stance phase and try and reduce the eccentric lack of control for the Achilles rupture. Could we manage this with an insole? No, we can't manage this with an insole. We can give them a little bit of medial lateral instability maybe, but we ultimately cannot replicate what has been lost either eccentrically or concentrically with an insole. What about this patient that presents with an acute tibialis anterior rupture? They're not suitable for surgery. They don't have any specific pains, but remember that the function of tibialis anterior is to control the rate of descent at the foot at initial contact, not just dorsiflex the foot. So therefore, we must consider a device that tries to mimic that. And again, you're right, referring for an ankle foot orthosis is absolutely correct, but we also need to then think about those things when we're thinking about the design. What about this type of patient? They present with a functional weakness, but now they have a fixed mechanical equinovarus deformity. And what are you going to do to refer this patient for? You might think that maybe they need an AFO. You might think that maybe they need footwear to be able to accommodate this deformity. And you're right to refer them for those types of queries and questions as to whether or not that's appropriate for that patient. But this is what can also be done for this type of patient. This is called a Charcot-resistant orthotic walker, and we use those for active and unstable Charcot joints. But we can also use it for other different presentations. And in this case, we've been able to use a clamshell, so we control that foot and ankle deformity from the top and from the bottom. And then I have a foot plate that I've put on the bottom to mimic the location of her normal anatomy and foot progression to not have a negative impact across the knee or the ankle or the hip. So we prescribe our functional foot orthosis. We're incredibly proud and very happy, and we're patting ourselves on the back, and we think we've all done a great job. But then unfortunately, like a fine rose, it comes with a thorn. And in the presence of orthoses, the thorn is our footwear, because our footwear will dictate what our orthoses will do. Yes, the aim of an orthosis is to apply forces to influence what the foot is doing when it interacts with the ground, but the ground and the interface between the foot, the shoe, the ground are changing constantly, and therefore it's very important for us to understand the environment that patient is walking in and also the shoes that they wear. So what footwear advice should you give? My advice first is to try not get caught into advising specific brands if you can. And the reason for that is you give them that brand, they're going to come back to you to say that brand doesn't exist anymore, I can't find it, please help me. So work on characteristics, and that will allow them to have a bit more of a broad spectrum of what they could find. So work on maybe the advice of having a shoe with a heel pitch. Maybe you've identified that patient has a tight gastrosoleus complex and they have forefoot pain. Advise them with a shoe with a differential to accommodate that. Maybe you've got a patient with midfoot arthritis and you advise them to look for a shoe that's got stiffness across the midfoot to minimize the movement across the mid-tarsal and tarsal metatarsal joints. Maybe you advise a person to look for a walking shoe that has got forefoot stiffness in the presence of either a plantar plate injury, a symptomatic hallux rigidus, or maybe you ask them to look for a shoe that's got more compression in the presence of a stable foot with fat pad atrophy. Maybe you also want to advise them to just get something that goes above the subtalar joint or the ankle joint in the presence of symptomatic post-traumatic arthritis. Remember that unfortunately, you're not going to get to change their entire wardrobe. So focus on the footwear that they are wearing for the majority of the day, majority of the week, and that's the best way to manage your patient. How often should you wear an orthosis? It's a very difficult question to answer because it's varied upon so many different things: their age, pathology, the tissue stress, the footwear, the environment they wear, and things that you haven't even thought about. And every patient will have their formula of how long they wear their orthosis for to be able to give them the right amount of acceptable symptom relief. And for them, that's the right answer for most of our patients in the presence of arthritis, and some tendon issues. We may become a little bit more regimental when we have someone that has a stage 2 tib post tendon dysfunction, because we're trying to reduce the need for them to have surgical intervention. But on the whole, we must let our patients try to come up with the right formula for how often they should wear their orthosis. So let's now go back to a case study and we'll look at symptomatic pes cavus. So you all know the Coleman block test off by heart, and it's all part of your exams, and we've indeed had a talk about that recently. But remember that what happens is you get that patient to stand on a block, that first ray is allowed to plantar flex and the hind foot corrects. So therefore you refer them for an orthotic assessment, advising that the Coleman plus block test has been positive in influencing that foot deformity. But then we have a problem because that patient is not able to put 1 centimeter that you used in a Coleman block test within their shoe. So maybe look at your Coleman block test and use maybe a 5 millimeter thick Coleman block test and then a 10 millimeter thick Coleman block test. Maybe that might tell you how much elevation, what type of osteotomy elevation you require and how powerful that needs to be in order to influence that foot type. And when we are treating that patient, we need to treat them not only with the reverse Mortons, which we showed in a slide before, but we also need to try and increase the ground contact because they have contact through just the heel and the metatarsal heads, meaning that they have constantly fighting for balance. And in some cases, we need to accommodate the forefoot equinus with maybe a heel raise built in and some advice on wearing shoes that have a slight heel pitch. What about our diabetic patients? Remember that with good vascular and diabetic control, pressure is our only enemy and is the only reason, apart from the patient's compliance, of course, that is causing that ulcer to break down. And remember that we talked, and I said earlier, that we're not just trying to apply forces to offload and control a deformity in the case of diabetes and a diabetic foot, we also need to control shear forces. And for that reason, the type of material we use has to be thought through a little bit differently. So this patient down here, what are we going to do, and what are you going to refer this patient for? Well, the first thing we want to do is to distribute the pressure more evenly. The second thing we want to try and do is apply pressure in some areas to offload that lesion on the second metatarsal head. And then when we've done that, if that orthosis is very thick and bulky, we then will need to encapsulate that in a shoe in order to be able to fit that device inside. And in some cases, we will then add a rocker sole adaptation, because a rocker sole adaptation will change the amount of time spent on that forefoot. And it's not always about where you take pressure, it's about how long you take pressure for. So the use of a rocker sole adaptation can also influence that area of pressure. So when should you refer your patients? Yes, we've talked about the ones before, but maybe also you refer your patients when you want to use an orthosis diagnostically with your pes cavus and your plantar flex first ray. Maybe you want to ask for more information about the mechanics of how that foot and ankle is working to be able to allow you to make a surgical decision. Or maybe you want an opinion on the pathomechanics of how that foot is functioning, and maybe then other things that you may need to consider if you're looking at listing that patient for a surgical intervention. Ultimately, the role of me as an orthotist and some of my podiatry colleagues in the prescription of functional foot orthoses, what I need to do is understand the structural deficit and your management plan of how you're treating your patient. I need to consider the pathomechanics and determine the forces acting upon the foot to allow me to design and prescribe the right device. I need to understand as much as possible the patient, their work, the footwear they wear, the level of pain, the history, their motivation, in order to understand whether I need a carrot or a stick. And I need to try and also educate the patient, because these patients have been with you for 10 minutes, something like that, and they always have more information. They're always looking for more information. And we need to come up with a measured response. 7 out of 10 pain needs to be treated with a 7 out of 10 intervention. So it's, again, very important for me as a clinician to understand where your mind is at, what you are looking and considering of doing if they fail conservative interventions. I then need to capture the data, either by taking a mold, a 3D scan, whatever it might be, design the orthosis, and then write a clinic letter to you to tell you why I have done what I've done and the reasons for, and then I instigate that management plan. So with that in mind, it's really important for me and us in the conservative management of foot and ankle to understand that surgical decisions are being made based on the outcomes. So it's very important that we get that right for you and for our patients. So in an ideal world, what should you put on your referral? In an ideal world, a clinic letter is always preferred with your examination, your diagnosis, and your management plan. That is the gold standard. If that isn't possible, then the pathology and your aims, whether that be to reduce pain, offload the first metatarsal head, increase the level of balance, trying to avoid surgery, all that information is invaluable to me to allow me to be able to make the right orthotic decisions for your patients and improve their symptoms. Thank you very much for your time.
Thank you very much, Nick. That was a lovely talk. You have given lots of examples about specific conditions and cases. And you have finished well in time, which gives us a very good opportunity to have some real good discussion for trainees mainly who are going to appear in exam. Before I open the floor for discussion, there was one request, Nick.
Yes.
If you can go back to your slides, is it possible to go
Yes.
back? And they wanted to understand the tarsometatarsal joint arthritis, the midfoot arthritis. Remember that?
Yes, of course. Yeah, of course.
So if you can explain it again,
yes,
please. Thank you.
Very happy to. Very happy to. Oh, there we go. Okay. So there are a large amount of patients that will have flexibility across their midfoot, and they will have tightness through their true talar crural joint. So you will do a silver-scoid test and you will identify that patient with knee extension has -5 or -10 across the foot and ankle with knee extension. The body takes the path of least resistance. And in the presence of these patients, the path of least resistance is usually either forefoot abduction through the midfoot and usually dorsiflexion and extension across the mid-tarsal joints. That causes a bending moment or turning moment about the tarso-metatarsal joints, and it causes compression across the top of the midfoot. So as a result of that, that is where sometimes they're getting increased compression across that area causing symptoms. So what we're ultimately trying to do is to reduce the stress and the strain and the amount of forces acting upon either the soft tissue or the joint. So by plantar flexing the foot, by accommodating with a slight heel pitch, what we can try to do in conjunction with other types of intervention is to reduce the compressive forces acting upon the midfoot.
Yeah, it does make sense, Nick. I mean, are you saying that we cheat a little bit? We allow...
Oh, we absolutely cheat. Absolutely. We rely so much on our midfoot to get away with so much. And our midfoot, we owe our midfoot an awful lot. And as soon as we are tight through our ankle, the body takes the path of least resistance. It's the laziest thing on the earth. And it is much harder to move through the true talar crural range than it is to just forefoot abduct and find another way.
No, that's very good. Actually, it does make sense. Now, I will make some comments. I made some notes here. So things which I've actually picked up from your talk is I was going to ask this. That in your view, what are the indications for off-the-shelf orthosis versus custom-made? And you've given the answer in a way by your test, the supination resistance test, which I think is quite useful. I've not done that, but it does give me some insight as to test how much force you require. Are there any other examples where you think off-the-shelf orthotics could be helpful, Nick?
Yeah, so I think one of the most underrated type ways of intervening is the good old-fashioned heel raise. I think it's an incredibly powerful way of managing foot and ankle pathologies in the presence of patients that have a large degree of forefoot abduction, and they have compression across the lateral border of their shoe and therefore have a Morton's neuroma or something like that. They often have, a larger degree of forefoot abduction when they are flat compared to when they're in a slight heel. And remember that patients that have ladies that say they have a very broad foot are always still able somehow to manage to squash their feet into a very tight toe box in a high heel. And why is that? The reason is that because when they go into high heel and we accommodate the gastroancillus complex, the forefoot becomes more malleable to compression. So the heel raise is a very, very simple and powerful tool in influencing and offloading the forefoot.
I'm sure, Nick, if I say this to my lovely ladies who come and see me for bunions, that, yeah, the answer is to wear heels, they'll be very pleased.
It's a metaphor. It's not meant to then be allowing you to change up your patient. But yes, but you get what I'm saying is that you'll get patients that stand, and even if you get them to stand and you put your fingers either side of their forefoot and try to compress that foot, the foot won't compress. But as soon as you put them in a bit of a pitch, try to compress that foot again, and all of a sudden that foot just changes. The load on the tissue changes, and that's what we're trying to do. We're trying to reduce load on tissue, not support arches.
No, absolutely. It does make sense. And in fact, for all the patients who I see with Achilles tendinopathy, I always ask them to wear a bit of heel.
Absolutely.
Yeah. Now, you did mention about the rocker sole.
Yes.
You talked about it when you're talking about diabetic or Charcot. I actually advise my patients to use rocker sole, especially in the presence of midfoot arthritis. Am I doing it right, or that's not?
No, I don't. I think what we need to try and do is to get our patients off their feet as quickly as possible through heel strike but remember that rocker sole adaptations don't exist in footwear on the high street as much as they used to. And whilst the MBT shoe did exist years ago, there have been lots of damning reports about that type of design of shoe. For me, we have to be very careful about rocker sole adaptations. I think they are very good in the presence of some types of diabetic foot or those non-specific. So if we've got a patient with this non-specific metatarsalgia, and we're querying whether or not we should be doing elevation osteotomies, We want to make really sure that that elevation osteotomy is going to change the outcome for that patient. So sometimes the use of a rocker sole can be used diagnostically to completely offload the forefoot, to understand that if we reduce the pressure off the forefoot completely, will that manage their symptoms? So, you know, the ones that you're just not sure, you're just not convinced, you don't see the callus, they don't have a tight calf, you're not convinced that an osteotomy is going to change that symptom. I think they're very good diagnostically, but who wants their footwear adapted to have a rocker sole adaptation? Not many. And how many pairs of shoes do patients have? Loads. So trying to get a patient to be consistent in using rocker sole adaptations, I think is very, very hard thing to do.
Okay, I've got loads of questions for you, but I'm getting some from audience here,
Okay.
so I'll start the audience questions. So there is a question saying that they're essentially asking about fixed versus flexible. So they're saying,
Yes.
I heard in another talk that those patients who have mobile or correctable joints are amenable to orthotic treatment, whereas what about fixed? So what do you think about that, Nick?
Yeah, absolutely. Great question. So yes, in the principle of feet that are flexible, we want to be applying high levels of forces to try and influence the foot, change the foot position and offload tissue. And in those instances, we can use a combination of hard, strong materials with softness for comfort and compliance. In the presence of an accommodative and a rigid foot, as an example, in the cases of a stage 3 tib post, then we want to accommodate that foot position, or indeed in the case of a Charcot that's quiescent, we want to use an orthosis that is not going to be applying high levels of pressure to try and influence that foot. Because the foot is rigid, if you start applying wedges and posts and things, they'll ultimately just be things that apply an uncomfortable pressure. So we tend to use a more accommodative device, and we also then sometimes use material that might be a little bit softer. Because if we've got a foot that's rigid, it's lost its ability to naturally shock attenuate. And therefore, we want to try and give that back in other ways, sometimes through the selection of softer, shock absorbing, shock attenuating material.
Okay. Somebody has asked again that they want clarification about rocker sole, about the diagnosis. So they're asking, is rocker sole a diagnostic tool or is it a therapeutic tool? And if diagnostic, for diagnosis of what?
It can be diagnostic in the identification of whether or not you offloading the forefoot completely gives a patient symptom relief in the case of a non-specific metatarsalgia, where you as a clinician are not convinced that an elevation osteotomy is going to be beneficial.
Fair enough.
So some are barn door, you think, all right, I'm going to do either a proximal release or a hook, or I'm going to do something to change the mechanics of why there's pressure in the forefoot. But when you've got those that have good ankle range and there doesn't seem to be any callus, I think making sure that pressure isn't a problem is a rocker is a good adaptation, where we take someone's shoe and we physically add that adaptation into their own shoe, is a valid request for us to consider.
So in other words, if somebody comes to you, complains of forefoot pain, there is no Morton's neuroma, you cannot see any plantar callosity, there's no significant tightness of gastrocnemius, you might want to put them in a rocker sole to see if that helps.
Absolutely.
Okay.
Absolutely.
There is another question about rocker sole. What are your feelings about the use of rocker sole adaptations to address first MTPG? They have not asked first, but first, I presume they want first MTPJ arthritis.
So I think that there are a lot of walking shoes that are stiff sole. So when manufacturers make shoes that are stiff, they invariably know that they want to have a very slight pitch within their shoe. So most walking shoes will have a little, what we call a toe spring, where that the front of the foot scoops up. So I think rocker sole adaptations in a high street shoe is an excellent idea for someone with the arthritis across the first MTPJ. But what you'll find is that that patient doesn't want to just wear that shoe all the time, because they want to wear different types of shoes. And that's where the functional foot orthosis with a Morton's extension allows them to swap that between different shoes to give them that stiffness and that variability in wearing different things.
So Nick, that actually brings me to my next question, which is, again from the audience, what are your tips to improve the compliance in orthotics?
Yeah, rule number one is education. The most valuable thing we give our patients is education. If we can try to educate our patients and give them an understanding as to why a device has to be designed a certain way, there we have more chance of making them compliant. The next thing I would say is that for every pathology, there are at least 4 or 5 different types of orthoses that you can design on a graded scale of complexity and bulkiness. And it's about that patient, it's about us making sure that we've taken the time to understand the patient, to design something. It's much better for us to design something that's 6 out of 10, that they're going to wear every day and fits in the lion's share of their shoes, than something that's theoretically beautiful but won't work in their shoes. So it's upon us as clinicians to understand our patients and design them to give the patient the best opportunity. So understand our patients and education.
Okay, so I'm going to ask you something now. So you've educated the patient has used the orthosis, and when do you decide whether the orthosis has not worked?
So I think that after a period of breaking in the majority of patients, I think 10 to 12 weeks with the use of an orthosis should be enough time to give that patient enough time to reflect on how they're doing and whether or not that intervention is valid and an appropriate way of managing that condition that way.
Okay, and how about people who try orthotics and say that the pain actually become a lot worse? Should they give up or should they continue trying? What should they do?
So that is a reflection on the design of that orthosis. If the forces causing that deformity are greater than the forces, if the forces of the insole are greater than the forces of the deformity, that's going to create a conflict between the foot and the insole. And in my estimation, in some cases, unfortunately, that's the design of the orthosis, and that needs to be changed. Therefore, it's for the patient to go back to speak to the clinician to try to get an outcome that is acceptable for them.
Excellent. Now I'm going to ask you one of my favorite questions.
Okay, go on then.
I mean, I know you've talked about Morton's neuroma.
Mm-hmm.
So when I researched it, I didn't find any level 1 or even 2 evidence to say that Morton's neuroma, the orthotics help.
Yeah.
And to my mind, Morton's neuroma is due to compression. So if you add anything, as in pressure, inside an insole which causes more pressure, how is it going to improve the pain? It's going to make it worse. And that's what I actually anecdotally hear from a lot of patients as well. So your thoughts about Morton's neuroma, role of insoles?
Thank you. So I absolutely agree that why do we get the pain within the second and the third web space? We get it there because that's the crescendo and the peak center of where that pressure lies. And these patients are getting a large degree, as I mentioned earlier, of forefoot abduction and compression against the lateral wall, causing that area to be in that peak area of pressure. So, like I said, you can get good symptom relief by reducing that compression and that pressure. And I've always been told, oh, well, Eskimos don't get Morton's neuroma symptoms because they wear that broader shoes. And it's always the patients that come during the winter months that have that issue. So it is a case of understanding. I think some of the research is very weak. I know you know that. But also some of the studies that are done, there's never really clear understanding of the design of the orthosis when they're looking at it. So I really think that I can, and I do get some good results with patients where we accommodate the range across the ankle in conjunction with trying to offload the metatarsal heads and increasing the interdigital space. I would say that the amount of referrals that I get for Morton's neuroma has changed dramatically over the past 2 years because of where I work, and patients seem to do very well. So I think it's geographical as to what a patient is going to be prescribed and how they're going to be managed with neuromas. But I think there is definitely scope here for a bigger study on that. And I'll be very happy to be part of that.
No, that will be great. So Nick, actually, I'm going to be practical here. So patient comes to me. I don't know whether you have experienced Morton's neuroma or not, but I have experienced that pain. And when it happens, patients sometimes are in agony. And if I tell the patient at that time that, look, I'm going to refer to an orthotist who is going to see you in X number of weeks, take some molds, and then make an orthosis, which might or might not be. Do you think that's a reasonable approach, or, you know, try injection first?
I think we have to follow the evidence. And at the moment, the evidence is that injection is a really, really valuable, powerful tool. And we must follow the evidence in everything we do. But what do we do about those patients that are coming back from an injection that are not responding? And I think in that instance, before we start sharpening our knives and heading towards stump neuromas, I think we need to take a thought of, let's try it and see, can we give you the comfort to avoid what may be inevitable?
Okay, no, that's a reasonable approach. I like your idea and suggestion. Talking about the same forefoot pain, so somebody's asking about now metatarsal pressure. So they are asking, what is the best way to offload the metatarsal head? Is it metatarsal domes or creating sinks, cutouts? Which is the most effective?
I think sometimes, the application of the dome, and sometimes in combination with a metatarsal bar, in combination with controlling the foot, is more powerful. In some cases where we've got a very stiff, rigid foot, a sink is very helpful. But sometimes in a very flexible foot, in my own mind, providing a sink for that metatarsal head to sink even further just doesn't commute properly with me. I want to be able to apply a pressure in the other direction and offload it in that direction if I can. But when we've got a very rigid fixed foot, or a forefoot equinus or an equinovarus deformity, if we've got a very specific localized area of pressure, then I think a sink is very, very valuable. So they're all applicable. The challenge always is, how thick is an insole going to be in the forefoot? Maximum thickness is going to be between 4 and 6 millimeters. And 4 and 6 millimeters of anything is not fantastically shock absorbing, because in order to be shock absorbing and cushioning, that material needs to travel a certain amount of distance. So therefore, your work needs to be done before just the cushioning bit. And that's why it's a combination of things. It's distribution of pressure, loading up other areas to take a weight off, and then shock absorption. So distribute pressure, offload, and shock absorb.
So moving on from the forefoot to the midfoot, I did ask you that I ask my patients to use rocker soles for midfoot arthritis, and you said that that's not great. So somebody's actually asked it, what's your recommended orthotic device for midfoot arthritis? Yeah.
So the first thing would be to, obviously, like we talked about before, is to accommodate the tightness that will exist across the midfoot in the lion's share of people, and that's with a device built with a heel raise built in. The second thing is to use a stronger and stiff material, because we want to try and support the medial longitudinal arch and prevent any sag of that midfoot if we can at all. And we usually achieve that with a strong, stiff material like a polypropylene or a carbon fiber or something like that. But then in order to make it comfortable, we would normally then use a soft material on top. If we have a patient that has got really fragile skin, they're very sensitive to the pressures that can be applied, then we can use softer materials. But I anecdotally don't believe that will be doing as much to influence the midfoot compared with a strong, stiff material with an accommodation for tightness.
Thank you. How about plantar fasciitis, Nick? Do orthotics help, number one? Number two, which type of orthotics help? The soft, the silicone gels, or like firm supports or hard supports?
Yep.
And third, do they need to be custom made or off the shelf heel insoles are useful?
Wow, that's an hour presentation on its own, isn't it? So, like all things, when there are 7 or 8 different modalities of intervention for one pathology, then we all then should easily assume that we're really not sure what is the right thing to treat our patients. It kind of feels like pass the parcel. We are treating with either shockwave injection or insoles or stretching, and wherever that patient's symptoms start to improve, and where it stops, that's what's the thing that helps that patient. It's multifactorial, isn't it? I think a heel raise is a powerful intervention. I think that the use of an off-the-shelf insole it's been shown that off-the-shelf is just as powerful as custom. I think the use of a custom device I would use when I've got a patient that has other comorbidities or other things going on within the mechanics of their feet, where they've got, maybe they have a high supination resistance, they've got very tight calf muscles, they've got all these other things that are going on. And like that diagnostic sieve, you are trying to influence as many structures as possible, hoping that that might be contributing to the plantar fasciitis. But injection is very powerful. Shockwave is incredibly powerful. And we know that physio and stretching are the lion's share of where our patients should be for plantar fasciitis.
So I'll going to go back to that because I'll focus on orthotics for plantar fasciitis. So I have a patient who does not have any deformity.
Yeah.
They have the classical heel pain going on for the last 3-4 months. They've tried stretching exercises, nothing has helped. Now, the question I'm asking you is, should they be using an insole which is just a heel raise, or should they be using a full length insole? And if so, whether it should be firm or it should be soft?
So I do think that it should be something that is firm. I don't think that the use of something softness plays a role here. I know that they feel like they're walking on a nail, but we still need to offer control and influence the dynamics of that foot and ankle. So I think firmness is definitely what we need to use. And there are some bits of research out there that talk about the use of lateral wedging to try and influence the fascia and the strain on the fascia. I can't tell you exactly that paper now offhand, but I would generally aim for a firm orthosis if I have someone that has a condition that's been going on for a year to 18 months. I want to give them every opportunity to try and resolve their symptoms if I can. But I'm not always confident.
Full length or just heel raise?
No, I think you can do that with a 3/4 length, so something that falls behind the metatarsal head. So 3/4 length.
Okay, all right. Now, another thing, I think we are running out of time. Very quickly, I'm going to ask. Now, you said that don't just say medial arch support for flat feet. So this is exam. So people who are appearing for exam, they see a patient with, say, for example, stage 3, pes plano valgus, somebody you want to try insoles. What should the candidate say?
So the candidate should say, based on my examination, I have identified that this patient has stage 3 tibialis posterior tendon dysfunction. What I would like to do is treat that patient conservatively. I would like to refer that patient for an orthotic assessment in order to try and influence the foot and ankle to try and offload structures that may be causing pain. That insole could be made from a firm material, and that material could have wedging in it to try and influence the foot.
Thank you very much, Nick. There are lots of other questions, but for the sake of time,
find me at the bar at BOFAS.
Thank you very much, everyone, and thank you, Nick, once again for an excellent talk. Please remember to fill the feedback which has been sent in form of a link, and also I would like to remind you about the last, I think the final lecture of distinction, which is on the 20th of March on FRCS foot and ankle BOFAS. Thank you very much. Have a good night. Bye-bye.
Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high-quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.